little slow at the very beginning as more and more join up, but this is a town hall about our future. This is done in conjunction with California ACEP and National ACEP. Really appreciate both organizations coming together for this very important topic. I want to start with what's bringing us all here today, and honestly, that I'm sure many of you have already seen the emergency medicine physician workforce projections for 2030. That ACEP did a great job of highlighting this back in April of this past year, and frankly, it really came down to that there's a projected potential oversupply of emergency medicine physicians within the next 10 years of all of our practice. And I don't know about many of you, but when I saw said report and the presentation, while I did appreciate it, there were a lot of immediate emotions that came out, and I was trying to be more honest about all of them. And I'll be honest with all of you that I was scared, angry, frustrated, and frankly, just confused as to what in the world is going on and how we got here. For those of you who know me, also know I've been doing a lot of self-work this past year and been really focusing on trying to always find the positives. So that's kind of what I started embarking in this journey. And frankly, I do think there are quite a few positives. One, this report started well before COVID, so this was going to come out one way or the other. However, it got released in the COVID contraction, and that actually, I think, brought a lot of attention to it that may have not otherwise occurred. And so it's good that we're now really focusing on this as organizations and individuals. And again, I think that's what's bringing all of you here today. I want to introduce some speakers here today who are, very honored guests and have done a really great job to bring this all together. And we're very honored to have Dr. Gillian Schmitz, who is the President-Elect of National ACEP, pretty soon to be the President of National ACEP. She works for the Uniformed Sciences Division. She is Vice Chair of Education, but she's done a lot of ACEP work in her background. And honestly, we're very lucky to have her, I think, at the helm at this moment, because she has been the previous ACEP Academics Affairs Committee Chair. She's been the previous Chair of Young Physicians, and she's been a previous board member of EMRA. So I can't think of anyone else who is better to lead us through this upcoming challenge than her. I'll turn it over to her in 1 second when she takes over, but I'm just going to also introduce the other person on this call who's going to be jumping in at times. For those of you who don't know Elena Lopez-Guzman, she is our Executive Director for California ACEP. She has now been with the organization for many years, has multiple expertise, especially when it comes to legislative, political, and policy expertise. I will tell you, if you ever want to get to know her, you literally just have to call the ACEP office and she will connect with any single member at any single time. So please never feel hesitant to not reach out to her about anything that California ACEP can be doing for you. And then lastly, I really want to thank all of you for being here today. There's quite an attendance, and this is a very needed conversation. So each of you has come to the table because you believe that this is the time where we as members need to come up with a solution. And I think as we go through this, I just want to outline what's going to happen. So we're going to spend 30 minutes of Dr. Schmitz going over some things National ACEP's doing. I will try to spend 15 minutes of what ACEP is doing. But really the bulk of this time is meant for you to share what are we doing right, what are we doing wrong, and what other ideas do you have that you want to bring to the table. I do want everyone to know this session will be recorded, so be mindful of what you're saying. In order to be careful that we're not over talking at each other, we're going to ask that everyone raise your hand on Zoom. Hopefully everyone knows how to do that by this point. It's under your reactions and you can raise your hand and we'll go and call on you. The chat is open, but again, because this is recorded, we're going to try to keep most of the conversation in audio format. So you can maybe share documents if you need to, but really, please, let's try to bring most of the conversation to the forefront. And then lastly, I really want to encourage this. Silence is not an option at this moment. This is our moment to shine. This is the moment where we're going to have to say what it is we want, because otherwise we're going to regret it in 10 years. So please, I will do anything in my power to make sure that you feel like your voice is heard right now. And let's remember what is going to drive us and bring us all here together today. And it's really the California ACEP mission statement. The vision statement there too, and you can read it on the website, but I'm going to read out the mission statement because to me, it is that important. The California ACEP's mission is to support emergency physicians in providing the highest quality of care to patients and their communities. And as we go through this discussion, I ask all of you just to always think, is the solution about the mission? And the mission is about physicians. With that, I'm going to turn it over first to Dr. Gillian Schmitz to go ahead and introduce herself and then go into slides. And I'm also going to ask when we get to the, because I can't go around and ask everyone to introduce themselves right now. Whenever you're asking a question, please take a moment to introduce yourself as to where you are and where you practice. So we'll do that at that time. But Dr. Schmitz, I'm going to stop sharing my screen and turn it over to you.
All right, well, thank you everybody, and good morning. It's good afternoon for me in Texas, but I'm Gillian. I used to practice in San Diego, so I consider myself a partial Californian, and I miss it very, very much, but it's great to see everybody. You know, I get that this is a scary time. There's so much uncertainty and fear, as you were alluding to, Vic, and I think when this first came out, there were a lot of misperceptions and misinformation that came out. And so my hope today is really to spread really a message of hope and of optimism. So if there's one thing you take from this, it's everyone take a deep breath. The sky is not falling. The world is not ending. There will always be a need for emergency physicians. The entire reason that we even did this workforce study was to try and anticipate what challenges we have that are in the future. Because this is what we do really as emergency physicians, right? Are there going to be some challenges in the road? Yeah. Are there going to be some unexpected obstacles that come up? Sure. But this is what we do every day on shift. We don't know how many beds are going to be in the hospital or what resources we have, and things get thrown at us all the time. So this is just one more of those days in the ED that, yes, there are going to be some challenges, and there are some big ones, but that's okay. And we embrace that change and really look for ways to continue to evolve as a specialty. So I'm going to share my screen, but again, I'm hoping to make this relatively interactive after I get through this initial information and really want to hear your questions. I will start by saying that in April, when we did the initial workforce rollout, at that point, we asked all of the different organizations just to throw out some ideas of possible things that they would consider as a solution. And lots of ideas came out from that. Some were good, some were not great, to be honest. And many of the suggestions that were made never made it past that initial day. I think some people have really grasped onto this is what the EM organizations are saying we're doing. And that's not really true. We've had now a number of months to kind of really rethink this. We meet every 2 weeks as a group, all the different EM organizations, to vet which one of the solutions is going to work and which ones, frankly, won't. And where should we be advocating for change at a national level to make sure that we have a bright future ahead of us. So I think a huge part of this is understanding the growth in emergency medicine residencies and really the supply chain of how things have changed over time. So I want to go through a little bit of this. And the workforce study really didn't come out of thin air. We've been looking at this really every few years to see what are the changes in the workforce over time. And what we've seen really is that the number of EDs has contracted a little bit, but the number of graduates, the number of residents has skyrocketed. And we knew someday this would happen, right? It's hard to believe now that 50 years ago, there were no emergency medicine residencies, but at some point, predictably in the future, we would start to reach that market saturation. So we have gone from 144 residencies in 2002 to today we're close to 275. And much of that growth has occurred in the last 5 to 10 years. Well, where did all this come from? So there's a lot of misinformation that is out there. If you look at the number of programs that have been approved, if you go back really from 2000 or 1990 to 2010, there were about 3 or 4 programs that were approved every year by the ACGME. And suddenly we saw this huge exponential increase. But this is a little bit misleading because around that same time is when we moved to the single accreditation system. So there were all these residencies that were approved by the Osteopathic Society before that then merged with the ACGME. So if you're only looking at the number of programs that the ACGME accredited, you would think that all of a sudden, oh my God, we approved 20 programs a year. Well, that's not quite right, because half of those programs already existed. They just weren't being counted by the ACGME because they were accredited by the Osteopathic Association. So when they got bridged into the same umbrella, it encompassed both new programs and the ones that already existed, but were previously only counted by the Osteopathic. So there is significant growth, but it's not as bad as some people have made it out to be. So when we look at really why are we seeing this growth, how is the supply changing over time? It's a couple of things. One is the number of new EM programs, but if you look at over time between 2014 and 2020, if we count both of those that were accredited by the ACGME and the AOA, there's really only been about a 15% increase in those 6 years. What's contributed larger to the change in supply has been existing programs expanding their complement. So instead of having 6 residents a year, 8 residents a year, they expanded to 10, 12, 16 residents. So it's the combination of both developing new programs, but then even the existing programs expanding their complement, which has increased an overall total number of EM graduates every year. So a lot of this question is, well, who is starting these residency programs? Is it the physician staffing groups? Is it the hospitals? Is it the health systems? Like, what is the motivation and where is this driving force coming from? So it's important to understand when we talk about the ACGME that to open a residency program, you have to have what's called a sponsoring institution. And this is defined as an organization or an entity that assumes the ultimate financial and academic responsibility. So this is typically a hospital or a health system. It can be a medical school. It could be a physician staffing group. But it's important to point out that currently there are no EM residency programs where a physician management group, staffing group is the sponsoring institution. Every single EM residency is currently sponsored by a hospital or a health system. And when we look at the players of who are the ones that are really opening residency programs, this is the list. And you'll see it ranges across all different types of ownership models: for-profit hospitals, nonprofit hospitals, public hospitals. And this sort of makes sense from a business perspective because there's a financial incentive for opening a residency program. And for those of you who have not been in GME, there's something called the cap, right, of how many residents you can open. And you get money from CMS. And in some states like Florida, you actually get matching state money for opening a residency program. But when you're at a hospital that we call a virgin hospital that doesn't have any GME, there is a huge financial incentive because you can maximize your GME spots up to 5 years. So there's a reason that hospitals and health systems want to start residencies. And when they do this, they go big. They open up EM, they open up anesthesia, radiology, family practice, however many residencies they can to maximize that cap at 5 years. And it turns out that of all the different specialties, emergency medicine is one of the easiest to start. One, because every hospital already has an emergency department. We're open 24/7, 365. We already have a staffed ED, and you have sort of a linear expectation of what kind of patients you're going to get. My husband is an orthopedic surgeon, and they have much more challenging time because they have to have specific types of bone cancers and specific types of pediatric injuries. But with EM, we can pretty much predictably anticipate how many chest pains, how many belly pains. So from a hospital standpoint, it's very easy to start an EM residency. So if you're trying to go for that financial kind of pocket of money, EM is one of the first kind of building blocks you build in your GME kind of outlay. So I'm hearing a lot as I kind of travel around the country of concerns that, CMGs are starting residencies. And I just kind of want to clarify that it's difficult to say that CMGs are starting residencies because, again, they're not the sponsoring institutions. It's typically the hospitals or the health systems that are doing that. And I can share with you that even my small Democratic group, who is in a major hospital in San Antonio, they're being pressured to start a residency program. And it's in everyone's best interest, right? They want to keep the hospital happy. Because if they don't, quite frankly, then the hospital will replace them with somebody who will. And so there's a pressure on who's ever staffing the group, whether it's academics, military, small Democratic group, corporate group, to really go with what the hospital wants. And if their plan is to expand GME, it's very difficult for them to say no or to walk away, or they will lose that contract. So how do we approach this? So one of the ways that we are addressing this is raising the bar and really looking at what is required to start a residency program. And quite frankly, a lot of the current standards were arbitrarily set when we started emergency medicine because we knew we didn't have enough. And we wanted to make it easier for people to be able to start residency programs. And so when the ACGME set this, we kind of put out standards that were, not necessarily evidence-based, but they were the best that we had at the time. And it's important, I think there's a lot of confusion with all the different alphabet soup of emergency medicine, that it's ACGME that defines and accredits what those standards are. Each specialty has its own, what we call the RRC, that will review those, will make recommendations. And ACEP and CORD and SAEM are all working together to provide what we think should be included in that. And we will discuss that and submit that to the RRC. But ultimately, the RRC makes their recommendations, and the ACGME board, who is not made up of any emergency physicians, determines what, if any, they're going to take. But what are we proposing, or what are we considering? So one, we're looking at things like procedures. There is some really robust evidence for some of the procedures that we do. So one of them being intubations. We've talked about, the guideline now is, I think, 35 intubations for a resident, and up to a third of those can be done on a mannequin. I don't know about you, but intubating a mannequin is nothing like intubating a real person with angioedema or a bloody airway. And there is actually very good data from the anesthesiologists that said even in a controlled operating setting, you need at least 70 intubations to be competent, probably even more to be proficient. And those are in kind of really normal airways, not much the difficult ones. So things like that we can look at raising the bar on that. Secondly, we're looking at scholarly activity. This is important not just for residents, but for faculty. What should the bar be for producing really research in academic medicine and contributing to kind of the science of emergency medicine? We're looking at what are requirements for faculty. Now that we have evolved into ultrasound and toxicology and pediatric EM, maybe we need to raise the standards on the types of faculty that are employed within an academic program. Maybe we should require that every program have a pediatric emergency medicine and a couple ultrasound fellowship trained emergency physicians to ensure that we have the highest standard for the future. And we're also looking at geographic requirements. There has been some rumors, right, that some programs might be flying in a research director to do their 4 shifts a month and then fly out of state. Well, that was never the intent of residency. The people in the core faculty are supposed to be there to help mentor the residents, to help them with their research projects, to help them with journal club. So we're going to be looking at really defining criteria for not just procedures, but for the faculty, for the facility itself. Right now, the only requirement is 30,000 patient visits at your primary site, regardless of how big a residency you have, whether you have 8 residents or whether you have 200. So maybe we really need to look at some scaling of what those patient volumes should be, and if the number of residents should correlate with the number of patient exposures or the number of primary patient visits we have at the primary or secondary sites. So all of those things are kind of being considered right now and vetting within all the different EM organizations. We're ensuring that business interests do not supersede education or patient care. So that list I had up a couple slides ago of who is opening residencies in the last 5 years, we are meeting with each and every one of those organizations. And this is where I think ACEP really shows its value. I think if any other organization tried to reach out to HCA and said, hey, we want to talk to you about workforce, you probably wouldn't get a return phone call. But we've worked really hard to set up these meetings to help show our data. And my experience so far has been that at first they didn't buy it, right? They thought that this number was so far off what they were projecting that they needed to see it. They needed to understand the data. They needed to meet with us several times to realize, like, holy cow, this really could be a problem if we don't address this. Maybe we should convert some of these slots that we've opened into fellowships or into psychiatry or family practice instead of emergency medicine. So this is where we have influence in ensuring that those spots are dedicated to where we actually need them and not just what's profitable for a hospital or a health system. We're working really hard on scope of practice. So this has been a huge issue on other providers in the emergency department and non-physician providers. And we want to ensure that nobody replaces the skills or the training of a board certified emergency physician. And we are doing this by fighting it on a national level and certainly at a state level of defining what that is, what it can look like, and making sure that we are vehemently pushing back against independent practice. We recently joined the AMA Scope of Practice Partnership. We've shared resources. We have been testifying in a number of states to help push back on harmful legislation. And we had some great wins this year, but we also had some tough losses. We're partnering with a number of other groups to look at our messaging, not to just legislators, but to the public, to help them understand who's taking care of you. And it's okay to ask, who is treating you? Is it a physician? Is it a nurse? What is the difference in training, and how important is that to your care as a patient? And we're also looking at an ED accreditation task force. Just like the College of Surgeons accredit trauma centers, what if we could accredit emergency departments and define a level 1, level 2 by the types of staffing models and having an on-site board certified emergency physician to supervise all care given in the emergency department. And this is such an important part because this is changing really over the last couple of years. You can see that now almost 25% of visits in the ED are by a PA or nurse practitioner. About half of those are seen in conjunction with a physician and half are seen independently. And ACEP, while we support physician-led teams, stand vehemently against independent practice. We're also looking at rural communities and knowing that we have to support emergency physicians in all communities. The fact is there actually are jobs out there. They're just not necessarily where people have wanted historically to work. But that whole middle third of the country actually has a paucity of emergency medicine physicians. And even within California and Texas and certain areas in our rural areas, there are no emergency physicians. And so if we're going to own that space, we have to be able to staff those emergency departments. And whether that's via telemedicine and critical access hospitals, whether it's preparing our residents to actually take those jobs, and instead of being in an ivory tower, right, where you have every single resource imaginable, to prepare them to be able to work in an environment where you may not have ortho or neuro or ENT, you may not have a CAT scanner. How do you practice, and how will we best prepare them for that change in their practice model? And lastly, we're looking at expanding demand. And this is kind of the exciting part of looking at how do we embrace the fact that we are continuing to evolve. And emergency medicine now is nothing like it was 50 years ago. And 50 years from today, it's going to look really very different than it is now. And that's okay. Change is not necessarily a bad thing. But I think the thing we've taken home from this pandemic is that our skills are not limited by a location, that we are a specialty, we are an expertise. And we can translate that knowledge and our really skill set outside of the four walls of a hospital. So this can be in things like telemedicine, and many people have really gotten into this during COVID, but helping to oversee care. And this is one group who has 150 critical access hospitals where you can work from home and provide kind of information and medical care as an emergency physician. We've been talking to CMS about opening up what we're calling emergency hospitals. Aside from COVID, if you look kind of pre-COVID at all of the data of emergency departments across the United States, 85% of patients are discharged. So we don't necessarily need more ICUs. We don't necessarily need general medicine beds in hospitals outside of COVID. What we need is more emergency departments, right? We need more rapid diagnostic centers to be able to meet patients where they are, to be able to do those workups and get them out of the hospital, which is the expensive part of healthcare, and more into a rapid, expedited outpatient center. And this is not just rural areas. So this emergency hospital is about a mile from my house in San Antonio, Texas, which is the 7th biggest city in the United States. So I think this is a model that's going to continue to evolve. So I do think there is light at the end of the tunnel. I think that we are going to have some growing pains. That's anticipated. We're not the first, by the way. Anesthesia also had a surplus that they predicted a number of years ago. And when they realized that was happening, they said, okay, we got to think bigger than just airway. And so they really branched into pain management. And now they have a whole new area to expand and grow into. We almost need our own pain, but there's so many opportunities of what we could grow into. The whole issue of post-acute care after people are discharged from the hospital or the emergency department, nobody owns that space right now. The whole concept of pre-hospital care, of triage, of urgent care, is the whole spectrum of acute unscheduled care. There's so many possibilities of what we can do. That doesn't mean you have to do that, right? There's always going to be a need for hospital-based emergency departments. And I hear that a lot from young physicians who do residency and want to go into that job, and I get that. But I can tell you, at least in my mid-40s, there are days where I'm very happy to slow down and not be in the hospital and do something different with my skills. We're also seeing 20,000 emergency physicians right now who actively have a license but aren't practicing clinically. So there's a number of other people who are doing other things, whether that's administrative, whether it's running a hospital, whether it's, med legal, cruise ship. There's so many different things we can do. So I think we have to kind of think bigger of what emergency medicine can be in the future and not limit ourselves just to the four walls of a hospital. And I know this, and I remain optimistic, because 50 years ago, this is where we were. We were the pit, the basement of a hospital with leaky exposed pipes. And they told us that emergency medicine would never exist. Emergency departments at that time were staffed by medical students. And they said there was no need for anyone to have expertise or training because students could do this, to put the most dangerous patients in the hands of someone who had the least amount of experience. They fought us, right? The pioneers of our specialty who went to bat for us, they were not well liked. They were not appreciated. And when we went to battle with this, we lost, and we lost badly with a vote of 100 to 5. So we've fought this battle before. I've seen this movie, and I know how it ends. And we're going to get there, because just like we did 50 years ago when we proved everyone wrong that we could become a specialty, nobody could have predicted then that in 50 years we would be on every single news channel across the United States. We would literally be in the White House advising the president on how to manage the pandemic and COVID, and looking to us for hope and inspiration. So I know this is a difficult time, and I want to thank each and every one of you for the work you continue to do in our emergency departments. I know we're all tired. I know we're exhausted, and I know there's a lot of anxiety and fear right now. But I hope that this has given you a little bit of hope that we're going to get through this pandemic. We're going to get through this workforce issue. This is just one more Monday shift where the waiting room is blowing up, but people are looking to us to help solve those problems, and we're here to help. And so with that, I will stop, and I'm happy to address any questions that people have.
Thanks, Gillian. Before we get to the questions, I'm just going to turn it back over. I'm just going to share what California is doing in the space as well, and then we're definitely going to open it up here. Let me go back to sharing mine. Lena, we good again? Okay, so I just want to, one, again, Gillian, thank you for coming. I really think this is we are honored to really have you here and to really share what National is doing. For those who don't understand, we are two actually separate organizations, but obviously partner very well together, and we're the subsect of National ACEP. So all the chapters kind of come together and become National ACEP. But in California, we also have our own separate board and have been trying to work really hard on this issue on each one of yours behalf. So let's just quickly talk about who's providing emergency medicine care in California. Gillian is correct. In California too, we have many rural sites. And so when you actually look at the map, you realize it's quite extensive. And all those orange dots are very small volume visit hospitals. As you get to the darker blue, those are like heavy volume visit hospitals. There are over 6,000 physicians practicing in emergency medicine in the state of California, only which 5,000 are board certified, to Gillian's point, that we do have the potential to grow even within our own departments. I want to also address, though, of those 5,000 board certified ED docs, only 3,500 of you are members. And I really appreciate you all being here because you are who we represent. And so it is important that we hear from you as to where you want us to go as an organization. I have been thinking about this problem for quite some time now, and I'm realizing that there are obviously multiple stakeholders in this situation. And one thing I really want to give Gillian credit, it's been under her leadership and the new executive director for National ACEP. Our partnership between national ACEPs and the states has grown instrumentally. And it's really important at this time that we are all aligned and coming together and speaking with one voice. But I don't want to take out the fact that really it all does come down to some of us as individuals and what we can do as an individual level too, because it will take all three pillars to actually make this stool stand. And then as we do this, and one thing I know California ACEP's board has really been focusing on is we've been trying to figure out what we can directly control, what we can influence, and then honestly recognize what we have no control or influence over, because otherwise we're just spinning our wheels for unnecessary moments. With that, here are certain things that I think we have direct control over, and I want to highlight them for you today. So Gillian mentioned scope of practice. As much as National ACEP has been very supportive of us, in the end of the day, this is a state fight. And this is something that California ACEP has been on the forefront for many years, actually. So really, can others be us? And as we all know, when Gillian was talking about the loss, that was a loss for us. Last year, AB 890, when the nurse practitioners gained independent, the ability to eventually get independent practice, because they technically don't have it just yet, they won the legislative fight. That was 10 years in the making. For as long as I've sat on this board, they have been trying to win that argument. And yes, they did unfortunately finally be successful despite all our efforts. But they're not done yet. There is another component to that, is that when we went and talked to all the legislators, they thought they're just passing it for primary care. Unfortunately, that's not the way the legislation is written. It's actually written that you can go into any space. And we do have hope that we can go back and ask them to reconsider that in emergency care, when it's undifferentiated, when you're at life-threatening situations, that we can go back and ask them to correct that, put their money where their mouth is, and sign a new law prohibiting that in emergency medicine space. It didn't work this past year, but just the way they didn't get it in their first year, it will take us some time. And I do want to promise all of you that California ACEP's board and our staff have not given up on that. On the flip side, there's a regulatory process that is currently underway, and I want to highlight what it is. It's a multi-year process. So AB 890 just set up the framework to say that yes, eventually NPs can get independent practice, but how and the nuts and bolts of how that actually is going to occur, that is actually up to the Board of Nursing and a specialized committee about this. There are 2 physician members on that committee, and Cal ACEP, we've already opened up dialogue with both physician members to start advocating why this is potentially not something they want to do in emergency medicine, in emergency departments. We do think there is an opportunity here to actually get what we want, and it might be through the regulatory space. And for that reason, Cal ACEP this year created a work group, which is being led by Valerie Norton, to help respond to any of the processes that occur. We want to be in front of the game. We want to be ready to act whenever they're proposing something to us so that we can address it. But I do want to also highlight that this is our opportunity as individual physicians to start taking some responsibility as well. If you're being asked to sit on a hospital committee or a group committee, now is the time to say yes, whatever the committee is for, because these are how you're going to make those connections and build those stakeholders so that when this conversation comes up at a hospital level, so it may pass the state, but it'll be up to each individual hospital to decide if they're going to do this or not, or each individual group to decide if they're going to do this. And if we can get in front of these now, we can actually hopefully maybe change it again in our emergency departments or other undifferentiated high acute care areas. And then lastly, don't forget about the public right now. Just like 3 weeks ago, I was at a pool in my complex, and I was just talking to one of my regular neighbors, and I kind of highlighted what was going on, and she was frankly appalled. And so we will need the public's help again when legislation comes back. So please do not forget that right now is an okay time to start telling people that, hey, this isn't looking good for you. This isn't looking good for care in the future. Let's also quickly talk about residencies, because I get this a lot when I'm on shift by some of you actually on this call today. Are there too many, and are we becoming too dilute of a specialty? In California, there are 34 EM programs already. This year alone, as Gillian had mentioned, it's not always the new starts that are actually creating more of a surplus, but we've had 260 new PGY1 spots. So that takes all the residencies have been actually growing. And I think it is important for us to realize that even if we stop new starts, that doesn't actually change our entire problem. And as Gillian mentioned, we can't stop. The Cal ACEP can't stop a new start. That is up to the ACGME. And I will tell you, I personally appreciate what ACEP is doing to try to influence the ACGME in that space. As Gillian mentioned, in certain states, there is funding available for new starts in addition to CME. And in California, that is from the 2016 Prop 56 initiative, which created something called Cal MedForce. And there's money from the tobacco tax that is then funneled to create new programs in certain specialties. Emergency medicine is one of them. We therefore got ourselves a seat at that table to help direct where that money is. And again, we are taking this very seriously. Our President-Elect, soon to be President, Dr. Lori Winston, is who represents us at this seat of the table. And we may be slowly telling them, you can give the money to other specialties like internal medicine or OB, because that helps our patients out when there are more of them available. So maybe we can try to focus on that. But we don't also want to swing too far, because at some point we might need some of this support. And then let's not forget the Cal ACEP influence. We are the largest state chapter for ACEP. I as the president of Cal ACEP, I may not have direct oversight over the ACGME or ABEM, but we do have some influence over ACEP. As it's noted, it's nice that Dr. Schmitz is here, but in order for us to actually be heard, we must get up and speak. And that also means we must grow our membership ranks. So I'm actually I appreciate every single one of you who is on this call today, but now is our time to get those who aren't on the call to also realize this importance, and those who are not members to start becoming that they need to be here to help answer this question. And then I want to focus on one last piece before we go ahead and open this up. So the business interest in medicine. Honestly, it's a balancing act. And for many years, as I've thought about this, the EM physicians used to equal pretty much our EM contract management groups. They were small institutions, maybe 12 of us. And so the interests were very similar, but that has changed over the years. And I've heard from many of you about this. We know private equity came in, we know shareholders came in, we know that groups have become multi-specialty, multi-state, and we know that mid-levels have been entering the ranks of these groups. I hear from many of you, physicians are losing control of the specialty and what we can do on the ground. And I really do think this is our opportunity to go back as these interests diverge as to who do we speak for. This is the moment where our mission and vision statement are paramount, in my opinion, and we have heard you. So Cal ACEP has submitted a resolution to National ACEP to be discussed at this year's council. Dr. Schmitz alluded that ACEP is already kind of doing something in this space when it comes to trying to accredit emergency departments. We're asking ACEP to, in that particular area, to actually start working about classifying EDs. We believe the membership has a right to decide what it is that we want when we're going through that space. And we believe the highest level rating should go to any emergency department that is truly believing in board certified EM physicians, that we are the best care for the undifferentiated patient. And we are taking a stand, and we are taking on your behalf. We heard from all of you, and this is our moment to influence ACEP, because I believe we are the best. And I believe hospitals love to brag, as we all know from the billboards we see of 5-star Medicare ratings, level 1 trauma centers. In fact, we've already been doing it with geriatric care for ACEP. I think this is the opportunity for us to be transparent to the public about what the care they're going to receive when the emergency department they're going to. And I think this might stop some groups from replacing physicians with other mid-levels, because it will come up with the cost of a decreased rating. And I believe in the end of the day, this is all about patients. We really need to protect them, because if we can do that, we can always win this argument. I, again, appreciate each and every one of you being here, but this is now your moment to let us know, what questions do you have? What have you liked what you heard? What did you not like what you heard? And then also, what are the ideas you want to bring forward? Because again, we can change the direction in this moment. So with that, I'm going to pause. I am going to ask again, raise your hand. And then also, please take a moment to introduce yourself, because while I know who many of these faces are, Dr. Schmitz does not. She might actually, but at the same point, we should be honest about that. So Gillian, anything you want to say before we start up here?
No, I thought that was fantastic. I'm excited to hear your questions, and I can share a bunch of different things if there's not a kind of where we're going on some of those issues you brought up, but great presentation.
All right, appreciate that. All right, we are going to open it up if anybody has a question that they would like to bring forward. Dr. Stock, by all means, sir.
Thank you, Vic. That was terrific. And thank you, Gillian. I really appreciate what ACEP has done on this report. I think it's really important and very timely. One thing I'd like to add, I don't know what it's like in Texas or in other parts of the country. In California, I believe we've been in a slow crisis that is sort of reaching a significant level in nursing, affecting emergency nursing and also nursing across hospitals. And given that, while we can do all these other areas, and I think they're all fantastic things to think about, including telemedicine outside the walls of the hospital, we're still, our meat and potatoes is being within the ER, within the hospital structure. So to address that, I think the crisis in nursing, as well as our workforce challenge, may have some solution in the middle. And while we're not going to become nurses, there is areas where we overlap. We certainly partner, and when nursing's in crisis, emergency physicians find themselves with problems with throughput and with care for our patients. So one example, as you brought up, the phenomenon of ultrasound and proceduralist type things that have gone on in the last 10 years have really exploded. The residents are terrific with ultrasound. They often get called by the nurses to start IVs. You know, a lot of our senior nurses are retiring. Younger nurses may have less experience in starting difficult IVs, and the residents come in and save the day, you know, every hour in my ER. So the idea of having, if you have a group, let's say theoretically of 6 physicians who have a small independent group, and they hire a 7th physician to be a proceduralist on every shift and can bill for those services, there's one area of workforce. We don't become nurses, but we help out in an area where nurses are having challenges and free up nurses to do things that they must do that we can't do. And I'm thinking about, you know, where can we partner with nursing to help where they can't meet the need all the time? What are your thoughts?
Yeah, no, I think that we are definitely relooking at, you know, where we're going and how we do that. I have a number of friends who are now full-time proceduralists, not just in the ED, but upstairs on the floor, because they're really the ones that don't know how to do central lines. Like, they were really struggling. I have one of my colleagues who's now running ECMO and got trained in critical care because during COVID in particular, their intensivists are just worn out and they needed extra help. So we have expanded really a lot into kind of the upstairs part of the hospital as well. I'm cautious a little bit with going into a nursing role, only because I think there is a set amount of money that most you know, departments have. And so I don't anticipate that for that 7th spot, people would necessarily be able to pay a full physician salary. And so we don't want to artificially deflate our salaries by hiring some emergency physicians at a nursing rate, although depending on some places, travel nurses I think are making more than emergency physicians in some places from what I hear. But there probably is a bridge that if we don't call it a nursing position, but you're helping with kind of throughput and proceduralists, of finding kind of what that right supply demand is to make it a salary that is inspiring and enough that an emergency physician would want to do it. But I think that's completely reasonable. And again, I think, it's when I was in my 20s, I thought, gosh, I'm going to work all nights and I want to do the high RVUs and all the time. And as I get kind of into my mid-career, there are days where I just like doing something different at a different pace. And I think that, this is a nice way for people to be able to do different parts later in their career that may not be the 2 to 3 patients an hour grinding, all the time, but that might be an option to say, I still want to work, but I want to do something a little bit different, but still help my department and function in a way that helps the hospital. So I think there's all kinds of room to explore that. It's a great idea.
Thank you.
Thanks, Larry, for that. Patrick C. Sean. Hey, Patrick, can you hear me? You're maybe on mute. There you go.
Are you able to hear me okay now?
Yeah.
Okay,
We got you.
Okay, great. My name is Patrick C. Sean. I'm a ER physician trained at LA County USC and actually work both in Texas and in California. I think that your idea regarding staging emergency rooms at different levels would be elegant, especially if that could be incorporated into paramedic ready net differentiations and even into reimbursement protocols. I think that would probably work really well. One thing that I've seen in California in particular, and I think you alluded to it, is there are travel nurses who actually make more than ER physicians. And part of the reason I think that has come to pass from a nursing point of view, and even the passing of the nursing practitioner legislation, is that they have a very well-organized union and group of members, quite frankly. And they've been able to pass legislation that mandates 4-to-1 nursing. And my question is along the lines is, I know it's a double-edged sword, but if we were to pass legislation stating that the hospital's owners are required to do, let's say, a 10-to-1 staffing of physicians to beds, then I think it could see a couple things happening. Number one, the nurses did sell this as a patient safety issue. And I do think that with sometimes the overwhelming numbers that are in the emergency room, having such model could in fact ensure patient safety. The other thing it's done, quite frankly, is it has created the need for hospitals to staff appropriately, and it's created a need for physicians to be recruited and retained. And what we've seen in nursing is it has created shortages, which has actually increased their salaries. And I would think that some sort of similar push for legislation by the American Emergency Physicians would also do the same thing of ensuring patient safety and ensuring, a certain supply demand balance so that physicians' salaries could be, I guess, improved or at least guaranteed at some level. I know that they've used an play model, which has allowed them to essentially obtain certain benefits, including due process also, which physicians don't have under an independent contractor model. So I guess my question or statement would be is, would it be wise, reasonable, or advisable to pursue some sort of mandatory staffing ratio for emergency physicians in hospitals and make the hospital groups, as opposed to the intermediate hospital contractors, bear the cost of that?
Great question. Lots of questions within the question. So there are currently in academic hospitals, there are some guardrails of how many people you can supervise. So that is somewhat already in place, but not so much in the community. I think that's a great question. I would bring it back to our DC office to look into the legislative ways to try to influence that of the state, the staffing ratio. I think the complexity has always been that, again, acuity is widely variable between different emergency departments. And the staffing ratios, it's hard to define. I've been at some places where I had very low acuity, where I could see a lot more, and others where I couldn't. And that's where I think we have struggled in the past trying to define what is the right ratio, even of an MD to a PA or nurse practitioner or resident. It depends, right? If I have an intern, it's very different than when I have a PGY3 resident. But I agree, if we look at just physician to patient ratios, assuming that you have like a middle of the line kind of acuity to allow for up and down scaling and variability, I think it's something certainly worth looking at. We have introduced legislation now several years in a row on due process. Raul Ruiz did co-sponsor that, and we are actively, fighting that on the Hill right now. And it actually recently just had another meeting with DC about that. So we continue to push for that. On that note, with kind of the corporate groups, one of the things that I think I can share with people now too is that we are going to be making a checklist that anyone who sponsors or exhibits at ACEP in the future is going to have to fill that checklist of, do you offer due process? Do you offer transparency and financial billing? Do you have restrictive covenants? A lot of those things that you will, hopefully, if we can get the technology to work, be able to scan it, with your phone, with your QR code, so that you can decide as a person what of those things are important to you. And this is the first year we're doing it, so I'm sure we're gonna have to tweak it over time, but maybe scaling of what is your ratio right now of physicians to patient is something that would be important to know. To understand kind of where you could scale up or scale down. But I think from a legal perspective, that's interesting. And I'd have to ask our DC office from a legislative standpoint if that's something we could advocate for. It has come up, should ACEP, unionize, can emergency physicians unionize before? And that gets a little tricky, and we're a little bit different than the nurses. And I will admit I'm not an expert on this and I'm still learning. But if you have any kind of ownership in your practice, by definition, you cannot be in a union. So that makes it difficult because you can't bring everyone in together. You would have to all be, and the other thing of a union is that you have to be able to strike to have an effective way to say you're doing this or we're walking. And I think ethically, many people feel that that is a line that emergency physicians would not want to cross, to say that we would all walk out on our patients. So there may be ways short of unionizing that we can still advocate as a group, as one voice on issues that are most important to us. And that's what ACEP's trying to do with this checklist and trying to do with certain pieces of legislation. But I can certainly ask about the staffing ratios if that's been looked at before, ways that we could try to work that in similar to the nurses. Great question.
Yeah, I just want to echo Patrick. Yeah, and thank you, Gillian, for that response. I believe, Patrick, something like that would definitely happen more in the state realm first. And I do think it's something that we could, of course, as a Cal ACEP member, we can always bring it up to the Cal ACEP board and it can be brought up at a board discussion, because I think it'll be something that's tested in certain states before it goes national. But again, great question on that. So, and Gillian, really cool idea about the QR codes and who's actually exhibiting. I really like that. So thank you for doing that. Jonathan, sorry, your last name's cut off on my screen.
Oh, hi, my name is Jonathan Balakumar. I practice in Los Angeles in the VA system as well as in the community. I really like this resolution in regards to grading emergency departments. We do use non-physician practitioners in the ED in both the VA and in the community, and I would not be opposed to getting a lower rank, because it will push us to have a physician-run only department, which I think is better for patient safety. So if it's like a B or C grade, I think it'll push hospital administrators to actually keep it physician-run. And I think that's a really strong positional argument you guys are pushing through.
So here's the challenge with it. So ACEP has done accreditation before. As Vic pointed out, we do geriatric and pain management, and we did it for freestandings. So in Texas, we had this whole model of freestanding emergency departments. And down the street from me, there was an ophthalmologist who opened up a freestanding, right? No ER training whatsoever. I was like, that is, and it was single coverage. So just an ophthalmologist. And it blew my mind. And we tried to fight it legislatively, but that was why I pushed ACEP to develop accreditation standards. And so our very first standard was, you have to be a board certified emergency department to work actually in an emergency department. You can't be an ophthalmologist and open up an ED. And the problem, we developed these wonderful high standards that were aspirational probably, but we're really pushing for 100% board certified emergency physicians. The challenge is that the hospitals didn't want to pay for it because they use other people in the department. And so if nobody is willing to pay for it, the program can't lose money. It has to be self-sustaining. And there's a cost, it's a pretty hefty cost to doing accreditation. So we have to balance having a high enough standard to raise the bar, but also find a reason that hospitals and health systems would potentially invest in this and to pay the $10,000, $20,000, whatever it is, to pay the accreditation fee. But it has helped with surgery. We know, like, if you wanted to be a level 1 trauma center, that's what helped hospitals get their neurosurgeon, to get their CT scanner, right, to get those resources. So that is the idea behind it. I think from what I understand, the task force is trying to bring in some payers to work with the insurance companies to say, hey, if you're a higher level, maybe you get paid more. And if you're a level 2 or level 3, maybe the insurance company doesn't reimburse as well. And maybe that would be a motivating factor for hospitals or health systems to pay for it. Or do you not market it to the hospital or health system? You just market it to the physician group itself and say, okay, are you guys willing to pay for this level of standard? And some groups will, obviously some won't. But that's going to be the business aspect. It's one thing to create the standards, but then two is you have to get buy-in from the group or the hospital to actually pay for it. And that's going to be, I think, the challenge in moving forward with this. But I'm excited to see where it goes and what the recommendations are. And I think what California is proposing is fantastic. Right? I've already heard, was it Kaiser in San Diego that recently made the decision to make it all board certified emergency physicians. That should be the gold standard. But from talking to many of my friends and colleagues who are in small Democratic groups, that would be financially impossible for their groups. They can't pay for a third physician, but they could pay for some mid-level coverage, and they have a great working relationship with the people in their departments. And are we shooting ourselves in the foot if somebody gets a B-, compared to something else? So that's really what we're going to have to vet on the council floor and see what our members think and think through sort of the unintended consequences of it. But I think it's a really interesting idea. And again, I'm excited to see where both the resolution and the task force are going to go with this.
Mm-hmm.
Yeah, thanks, Jonathan, for the support. And I agree with Gillian. This is a very evolving, ongoing discussion, and we are proud to be some of the ones that brought the discussion forward. I think, again, that's the power of Cal ACEP, is that we are opening up the discussion, and it's been a pretty interesting discussion. As someone who's been at the forefront of it now for a few weeks, I realize how valuable and important that discussion is. So, and I appreciate that ACEP is willing to have that discussion on the council floor. And if you really truly believe in it, it's not just even convincing Californians, it's now actually calling your friends in other state chapters to tell them that, hey, I think this is something we should do or not do. Dr. Kurtz.
Hi, Gillian, it's Alicia. Hi, Marco says hi.
Hello.
So I'm Alicia Gonzalez. I used to be Alicia Kurtz, but Marco and I eloped in December. And I work for Vituity currently in Central California. So I actually was going to raise this issue of using advanced provider coverage in the ER. I can't help but think about things like, for example, our reimbursement rates and looking at how tight those have become with insurance companies, and realizing that truly, like, if my ER or any of the last 5 ERs I worked in was to go to 100% physician coverage, the drop in our hourly would be substantial. And so there's a piece of me that also thinks that there's a lot of work that happens in the ER that I don't need to do, like that I do feel confident letting a PA see low acuity or doing a lac repair or putting a splint on while I see the sicker patients who maybe do have emergencies, but we're not going to be getting rid of those lower acuity patients because we are a critical access point to the healthcare system. And so as like an observer of how things have been going, I get a little bit uncomfortable at how I think negatively spun a lot of the conversation tends to go. And I can't help but wonder, would it be better, and maybe this is happening, so forgive my naivety, but would it be better to partner up with some of our emergency nurse practitioner and PA like SEMPA, and talk about what does the ideal working relationship look like, instead of saying that 100% only physician run ERs is the only answer. And I feel like you already kind of addressed all of that. So, but the second piece I was going to say is, there's a famous, well, to me, it's famous, like Amy Moulin comment, which is, why are we the only specialty that doesn't get paid for being on call? And I always think about that, like the ER, the volumes really fluctuate. And some days you're cranking at 4 an hour, and some days you're sitting on your hands, from 3 to 5 a.m. while nobody comes in. And it's really hard, I think, being in a fee for service or a fee for patient model when we're just like supposed to be there ready for anything that could happen but might not. So my question in that would be, has there been any discussion about maybe thinking about advocating for different payment models that might work, thinking about us being on call or just being there as opposed to only when the patients are there? And thanks for being here.
Well, first of all, it's wonderful to see you, and I'm still not used to your new last name, but congratulations to you. That's really exciting. And I know we were kind of focusing this one on workforce, but we can certainly kind of shift gears and talk about reimbursement as well. So yes, we are talking about that, and it kind of makes sense. And I think Amy's talked about this extensively of the whole public health service model, like the police department, the fire department, right? They get paid just for existing and for preparedness. When your house, if it ever goes up in flames, and I hope everyone's safe out there. It sounds like there's a lot going on with fires right now in California. But if that happens, right, you don't bear the whole cost of the fire department resources on your one house. That kind of burden is shared, from taxpayers, from the government, to help offset that cost, so that it is public utility and service. So should we as emergency physicians advocate that? I think we've learned, particularly in the pandemic, that we can't be dependent on volume because our volumes are unpredictable. And healthcare has widely been believed to be recession proof, but we're definitely not pandemic proof. And when we went down 40% across the country, it shut down, right, a number of hospitals that couldn't sustain that. So yes, we are looking at advocating for a model that would pay us on preparedness, and then have extra levels for the extra services we're doing, but having something just for keeping our lights on and being open, because we still have the same cost whether 100 people come in or nobody comes in at a given time. So that's point very, very well made. And thank you for sharing your comments. And I am hearing that from a lot of people too on how do we approach this? And I think, ACEP's position has always been that we believe in physician-led teams, and we recognize that there is an important role for many different people in the emergency department, and we are a team. And different groups use and staff different models. In the military, we have a unique situation, right, where I have to train my PAs to do some of the more intense procedures because they're in the field getting deployed and they're actively getting shot at. And when I have an American soldier who's dying, like, they need to be able to provide a chest tube and crate them, but that's very different in the United States civilian side, emergency department. But there's people on opposite ends, obviously, of that spectrum. And we're feeling a lot of that right now. And I think it's become exacerbated because of the workforce issue, that people are speaking maybe out of fear more than they are out of emotional. And there's also a generational difference. There's a big difference in how someone later in their career feels versus someone earlier in their career who sees that as a threat to their job security. So I certainly see both sides of that issue. We have worked with SEMPA and AAENP on trying to define levels of supervision. And I say that specifically to those organizations because they believe very clearly and recently reiterated they do not believe in independent practice. There are other organizations, namely the ENA, Emergency Nursing Association, who very much believes in independent practice and isn't shy about it. And in fact, it was sort of ironic to me. I went to a meeting, they got upset that the veterinarians were putting the word nurse because they didn't feel they were nurses. And I was like, well, don't you think it's ironic you call yourself a doctor? But that's a whole nother story. So yes, point well taken. Thank you, Alicia. Great to see you.
Yeah, thanks, Alicia, for sharing your points. And by the way, I just want to, as someone who's been running this resolution, we know that a lot of departments won't get to certain levels because of the reimbursement model. And that's okay, honestly. And in my opinion, I think it's okay. It's just being transparent to everyone as to what is happening. So it's not saying anyone is necessarily even that bad when you're getting whatever rating. I mean, maybe when you have no physicians there, that is actually a bad idea. But I think other than that, the idea is actually that we're just being transparent of what it is. And we should come out as a college and say that we are the best, that no matter what happens, we're the best. I also want to quickly highlight, it's 11:58. I'm sorry, Dr. Schmitz, no one asked you this ahead of time. I can stay late. I don't know what your timeline is like.
I can do another 20 minutes or so, then I got to pick up my kiddos from school.
Okay, so we will, there's 5 hands up. We definitely want to address the membership. So yeah, I will definitely stay on. So sorry about that. To anyone who has to drop off, by all means, please, again, thank you for being here. We really do appreciate it. And you're welcome to reach out to any one of the board members, myself, at any moment, and I'm happy to go over anything offline as well. But with that, Dr. Barnes, the floor is yours, sir.
Hey, thanks, Vic. Can you hear me okay?
Yes.
Great. First of all, I just want to thank both of you, Gillian and Vic, for putting this together. I think it's important that we have a voice, and I appreciate both of your leadership. I really appreciate the transparency around this issue. The town hall being made public. I've shared it with our faculty. I've shared it with our residents. It's an important issue that everyone needs to be aware of, and I'm especially appreciative of how forward-thinking our specialty is. I think anesthesia was caught off guard with their workforce crisis in, gosh, what was it, the early 90s, mid 90s. And the fact that we're a good 8 to 10 years ahead of our anticipated crisis, I think just speaks volumes to our leadership. So thank you both. By the way, I am the residency program director at UC Davis in Sacramento. We are a combined program, a military program with the Air Force. So we have the same workforce issues on the civilian side. We don't quite have the same workforce issues on the military side, but I just want to put that out there. I think it's an oversimplification that this issue boils down to a supply and demand problem. As a program director, I'm primarily focused now on the supply side of this. And I recognize there are a lot of barriers to solving the supply issue. There are regulatory and legislative barriers like the Sherman Act, and there are cultural barriers as well. How do you ask each individual program to make sacrifices with the size of their program or potentially the training duration without enforcing that as a blanket requirement across the specialty? And I think it's going to take some time to get that issue ironed out. But my question really involves the intersection of the supply and demand. And Dr. Kurtz brought up, that was a great segue to my question with the issue of us getting, working together. I think we do need advanced practice practitioners. And I think there is a way forward where we can work together collaboratively in physician-led teams to make that successful. But my question is specifically around the growth of advanced practice practitioner residencies and fellowships, and how the labeling of that is, I believe, in some part driving the demand for those specialty trained APPs, and how that may be part of the demand issue that we're seeing, especially in some rural communities. Even at an academic center like ours, we have subspecialty NPs and PAs who are touting themselves as residency trained and fellowship trained. Many of us in academics may be aware of the position statement that was co-authored by ACEP, ABIM, CORD, ACEP, CORD, SAM, et cetera, really speaking to their blanket position that the terms resident and fellow should be reserved for physicians in those training programs. And so I'm wondering, Gillian, specifically, if you can speak to what ACEP is doing, if anything, to address those, the residency and fellowship trained APP models.
Yeah, so thank you. I actually wrote that policy. That was my concept that I reached out to other organizations to co-sponsor with us because I feel so passionately about that. And I got a lot of criticism for it, but it's what I believe and what I felt like, that transparency is important and words matter. And we need to be clear about who we are because it's confusing to everybody if we don't. And I respect different roles that play in the emergency department, but let's be honest about who we are and what our training skills are so that patients know who's taking care of them. It is challenging. What I am seeing actually now, ironically, so the growth, and as a program director, the growth of residencies has largely in the last 5 years been in for-profit hospitals because people are trying to maximize their cap. As they are opening new emergency medicine residencies, ironically, they have removed all of their PAs and nurse practitioners. So the number, especially on the East Coast, the number of PA and MP training programs has gone down as they have started the emergency medicine residencies. Long term, what is that going to look like? I think it's interesting of also who's driving that. So I'm a graduate of UNC. I know many people are familiar with what happened there a couple of years ago when the hospital sort of forced a training program on them. It didn't even communicate with the chair or the program director, and it was announced on the news and all the medical students were freaking out. And so clearly we need more communication on that. But there is, a financial incentive again for training more people. And I don't think training is necessarily a bad thing, but I think we have to make sure that it doesn't impede with our residents. And so one of the things that we've talked about with accreditation standards and also with this ED accreditation is, if you have a residency program, do you have an MP or PA training program affiliated with it? And so the first thing is we have to get good data. So it's actually one of the objectives that I made for academic affairs this year. So we can track how many are in existence. And that gives us some data points of how quickly they're growing or shrinking or where things are going with the changes in workforce. And then model what is influencing that behavior. For those that do, right, we have to, and that's part of the reason of making this bar higher for procedures, is that we're doing more than just procedures. We're advocating that we need to really specify what is an adult resuscitation, what is a pediatric resuscitation? Because I think some programs are trying to say the 18-year-old with asthma or, is there pediatric resuscitation after one neb? You have to have enough sick patients for your residents to prioritize their critical care. So I think by doing that, you will address that because many programs, I know my program has a training program. We call it a postgraduate program, not a residency. But we have delineated roles, but our PAs and nurse practitioners do not work in our critical care area. They do not work in trauma. And any advanced procedures go to our residents. But on the community side, it may be different. And there are places, particularly in rural areas, where you may only have a PA or nurse practitioner now. So until we fill that gap or shortage, I still believe in education, but it should never be compromising the part of our residents. So what ACEP's doing right now is, one, collecting data of what currently exists and seeing what those trends are. And two, trying to raise the standard such that we can ensure that our residents are getting the highest amount of critical care and procedures and that it is not compromising their education or training.
Thanks, Dr. Barnes, and Dr. Schmitz for that answer. Let's actually go to a resident, actually, Dr. Perez, who is the future Cal EMRA President-Elect.
Hi, I don't know if you guys can hear me. I just wanted to thank you for being here and reiterate what people have been saying about. Thank you for the transparency with everything. I know, speaking from the resident side, the resident perspective, there's a lot of concern, and I think, one of the main questions I have, it sounds like there's a lot of things that have started going on, and it seems like there's a lot of things that have been set in motion to try and address the workforce questions and concerns. I guess the only question I have is, I'm wondering if a lot of the things that we're doing, do we see them as things that are going to be sustainable for, the next 20, 30 years? Are a lot of these just things that we're using to temporize for right now? And, and I'm just trying to make sure that I'm just wondering, are a lot of these things going to actually accomplish that? Because, like hearing about, like, once that report came out last year, I haven't even started practicing, and I'm just thinking about, oh my God, average med school debt is now, like, I think it's 215, something like that. And it's like, how on earth, and if it keeps going up, how on earth is that going to be, able to be paid off anytime soon? And, if I'm not able to even get a job. So again, thank you for being here. Thank you for all the transparency. It's just, that is a huge thing that I keep getting questions about, and, a lot of residents are voicing concerns about is, what are we going to do?
Right. Great question. And I definitely feel that fear. And, I am a mid-career physician, so I'm not going anywhere. I've still got 20 years to practice. So I'm heavily personally invested in this long-term, obviously, as well. But yes, I think all of those 5 pillars we proposed, none of those are short-term solutions. Each of those will take, time to implement. And by nature of doing them, they will impact things well into the future. There's also like those market forces that come into play. So with every workforce study, I'm probably dating myself, but did you ever watch Back to the Future, right, where he goes back? And so when you go back in history, right, by nature of doing that, you've already changed the future. It's kind of the same thing with the workforce study. By the time we published that, because of that, like that day, it already made those projections inaccurate. And that's a good thing. That was exactly why we did it, right? Because of that, there's already been dozens of medical students who would have gone into emergency medicine who are now doing something different. There are people who are like, you know what, I'm done with COVID. I have COPD. I'm going to retire a year earlier, right? All these things are happening as a result of that will already put these motions into place. And so the whole intent was, again, by doing this 8 to 10 years in advance and not waiting until like the day before, I'm like, is that we have time to anticipate, to plan, to adjust, and to like change our course as needed. But with that, we're going to have to survey the residents again and look at this study closer than we have been doing it every 7 years, but it's going to have to be closer now to see where things are changing because of that, and make sure that we are not overcorrecting. With anesthesia in the 1990s, they had this issue, but before that, they actually had another case where they projected a surplus, but they were wrong. And it took them a decade to recover, because what happened was medical students stopped going into anesthesia, and we saw this influx of international medical grads and different people, and it took them a really long time to recover. So whenever you're talking about something this impactful and this large, you have to kind of make baby steps and adjust and research, and how is this changing? Because you don't want to overcorrect and then be in a world of hurt either way. So it is kind of a question we're going to have to watch very closely. But I do think that there's been a tremendous amount of work on this in the last 6 months, and things are going in the right direction. And I feel really good about where we're headed.
Thank you so much.
Yeah, Josh, I just want to, 5 years ago, I was part of a hiring team for a group up in Sacramento, and we were hurting for physicians. And I used to kid, if you were at a Heartbeat and you were anywhere near an emergency medicine physician training, like you were hired instantaneously. And so we, let's be honest with all ourselves too. 5 years ago, we were burning out, we were short staffed, and we wanted anyone who wanted to be an emergency medicine physician. So I do agree wholeheartedly with Dr. Schmitz. We have to be careful. That's also why even on the Prop 56 side, we're being very careful and very tactful about how we're going about that approach. We don't want to come out and say we want no more residencies ever. Otherwise, when the time comes to need it, it'll be very difficult. So this is where I think the Cal ACEP staff has been very important as to how we message and market this. So with that, Dr. Nichols.
Dr. Schmitz, thanks so much for doing this. I'm Taylor Nichols. I'm an emergency medicine physician in Sacramento. I'm also on the board of directors of California ACEP. One of the questions that I had on the whole issue of APPs and our discussions, I appreciate you bringing up sort of raising the bar for EM residencies, and we really want to push that forward. I completely agree with that. But then we're also, is there any way to do anything about raising the bar for the education of NPs and PAs? Because we're not going to eliminate them completely. I agree with the idea of the credentialing, the numbering or lettering system for grading emergency departments. I don't know if there's any conversation between National ACEP and the PA and NP boards. I know the NP especially, they've done absolutely nothing in terms of standardization and raising their own bar. I don't know if we're able to have any influence on that. I was wondering if we are, then if there's any conversation happening there, and if not, if we would be able to use this accreditation process to say, hey, there has to be some level of standardization. You have to pass some sort of test to be within whatever a B versus a C or whatnot.
That's a great question. Yeah, so that brings up a couple points. So on the workforce, again, there were a number of suggestions that were kind of thrown out there as like throwing darts at the board, but some of them got kind of picked up, some of them did not. So one of them that came up was, could we look at creating standards for nurse practitioners and creating sort of a certification track of some sort? I will say that one has been one of the more unpopular ones because some fear exactly that. Like if you make a certification track and you give them a gold star, are they going to take that, diploma and say, look, I'm now residency trained, and use that to be independent practice. So it's very funny being in my role because I get yelled at on either side, which usually means I'm doing a good job of kind of staying. But my sense is that ACEP is unlikely to do that for that reason. It just politically, it's not our place as emergency physicians to tell other people how to do their job. However, AAENP, again, who is a good partner who does not believe in independent practice, has taken that up. They have created standards. They do have an exam. I have heard anecdotally it only has a 4% pass rate. I'm not sure. I haven't confirmed if that's true. But well, that could be a good thing though, right? Like maybe that helps us actually say that this is why you shouldn't be practicing independently. Like 96% of your people fail it. And please don't quote me on that because that could be wrong, but that was a rumor that I'd heard. But I think politically it's a little bit more tenable if a nursing organization runs with that as opposed to ACEP. But we can provide them the support. But I think they were able to pull those pieces together, looking much at our kind of board exams and certifications to say, you need a higher standard, because really what's the most dangerous thing, and if we're really interested in patient care, we don't want someone coming right out of MP school practicing in a department, right? That's terrifying. And that is actually happening. So there probably, and that could be something, as you alluded to, that the ED accreditation task force looks at. So even if it's not ACEP that's creating the standards or the certification program, it could be part of the accreditation standards to say, like, your bottom, your tier 5 or whatever that lowest tier is. If you are going to hire only nurse practitioners, for the love of God, please make sure they've had some kind of training, and then you're not just throwing newbies into the wind. So I think that's something that I'm sure that will be discussed. It's a very good point.
Dr. Basarai.
Hi, my name is Zahir Basarai. I work in Los Angeles at the VA, and also at one of the Kaisers and Harvard UCLA. And I first off just want to say that I really appreciate raising the bar for residencies and that being a primary focus. we're only as good as the providers that we produce in our residencies. And if we dilute that pool and have residents who aren't as strong, we will lose respect in the hospitals that we work in. I was fortunate enough to have Larry Stock as my attendee, and we threw down a bunch of crazy shifts at Harbor. So I'm only as good as he is. So, but with that said, you know, I do want to talk a little bit about the idea of giving ERs grades. And I think that's such an important move that we can make to kind of draw that line in the sand to establish our value as emergency physicians. I understand that there may be some short-term concerns like what Alicia was talking about with regards to how are we going to be able to have our, you know, our salaries be as high as it is currently without mid-level providers and us blindly sending charts of patients we haven't even seen. But in the end, this is about establishing the future of emergency medicine. And, you know, like I said, having mentors like Larry Stock, who basically allowed me to be in the position that I'm in right now, I want to make sure that I'm able to give future residents their, you know, a profession that they're excited to be part of. And right now, I think that there's a lot of sentiment, as I've talked to a lot of people who rotate or who work at the VA with me as per diems, who work out in the community, that they really are just not feeling good about the future of emergency medicine. There's been so much consolidation of big groups to the point where physicians in LA literally have no other option but to sign up for a group because the number of small democratic groups are so small. So I think that the idea of establishing, and I'm kind of bringing up a couple of different issues right now, but you know, to kind of circle back, I just want to say that I really support this idea, and all the physicians that I've talked to, that I work with, who work out in the community, also support this, even if it does mean that their ERs that they work with potentially aren't graded an A+ or whatever grade they get, but rather if it means that they establish for future generations the value of an emergency physician, then they're good with it.
Yeah, no, I totally agree. And that's why we've been kind of doing this in pieces for the last 5 years. But it was when we did the freestanding, it was always my concept that we would be accrediting all EDs at some point, but that was kind of our starting point. And geriatrics has done tremendously well. So I do think, and again, this has been, they started about 6 months ago. So that accreditation task force has already meted several times. Adrian Tyndall is the one who's chairing it, who's phenomenal. And I'm really excited to see where they go. It's the devil's in the details, and that is the business plan of when you really get into the nitty gritty. You know, how do you account for rural hospitals? What is the business plan? I didn't realize until we did the freestanding accreditation how expensive it is to do accreditation, because you can make those standards, right? But somebody could just lie and check a box that, yep, we do that. So you have to actually be able to verify and back up that information is accurate. So you have to fly someone out there to that site to like check on things and make sure that they're actually doing what they're saying. Otherwise, what's the point of accreditation if people aren't held accountable? So there's a significant cost to doing it. So anything that we make up has to have a pretty sound business plan of how are we going to pay for it. And that is, again, the big question of how do we, when you make something that's aspirational, that is ideal for us as physicians, but you have to have an incentive for hospitals to pay for it. So we have to figure out a way to balance those and find a way that is in a way that is good for emergency medicine, but at the same time, find a way to pay for it. And maybe it's not the hospitals that pay for it. Maybe it's the physicians in the group. Like that, I think that's what the group's going to have to look at. With regard to your small group thing, one of the things that ACEP's also adding this year is we're going to create a conference that teaches physicians how to start your own group. So for people who are fed up and just like, I don't like it, I don't have an option, let's make your own option. Let's learn how to do it to outcompete the other people in that marketplace if you can do it better. But you have to have a strong business sense to know how to do it, and also to expand beyond just the emergency department, because that model is not really sustainable in today's reimbursement world. You almost have to have cross subspecialties with ICU and hospitalists to be able to have that market power. So we are bringing in like the big guns of every small democratic group to really hone in on this, and I am really excited about it. So hopefully people will participate in that as well.
I think that's such a great idea. That's amazing, especially to, again, go back to the roots of emergency medicine and small democratic groups that basically made our specialty. And I just want to say, like, I think that I understand the financial concerns that go along with the resolution, but with regards to, I think the long-term impact of it, I think we have to, eat the cost if it means that, again, we're establishing the future of our specialty. And I think that if patients, my neighbor, for example, just had to go to an ER and was seen by a PA and didn't even see an emergency physician. And he actually went in with AFib with RVR, which is just, like, to me, mind-blowing that a level 2 patient would be seen by a mid-level provider. And I think that if the general public was able to identify emergency departments based off of the providers that are there, that would, in a sense, allow them to choose emergency departments that they want to go to, and in an indirect way, kind of force the hand of hospitals to pay for whatever accreditation they want. So
I hope so. I will tell you that that was not our experience with freestanding. We tried, people would put up billboards like we're a level 1, but patients don't always get it, right? I mean, half of them have like a 3rd grade education that they don't even care if they see a doctor or nurse practitioner. They just want to be seen in 5 minutes, right? They don't want to have to wait. But that is part of this, is educating the public and helping them understand the value of emergency medicine. And my hope is that that is the case, but it doesn't always bear out that way. But that's part of the whole discussion of how do you create this? How do you create the business plan to make this viable? But I think, again, I really believe in this. This was my kind of baby from the freestanding at the beginning. So I'm really excited that ACEP is moving forward with this. And it's just going to be a lot of work to figure out how to make it sustainable in the long term.
Gillian, I really appreciate taking the time. I know you have to get your kids. I want to go ahead and close. Dr. Stock, I'm so sorry. You are my mentor too, but I apologize to do that to you.
We can do one more question. Go ahead, Dr. Stock, and then I'll go get the kids.
Thank you, Julie. So I didn't tell you at the beginning, I'm a former president of the California chapter, and I help run a independent single specialty group in Southern California. We're going to next year celebrate our 50th year being a group. And so I want to challenge you as the president-elect to think about the model of emergency medicine that's here brought up, because that is the roots of our specialty. I'm sorry, there's a gardener in the background, so if you hear noise, I'm sorry. That I believe there are models that still work as long as the people in the group are focused on doing the right thing for the patient and working in all ways necessary to run an efficient group to meet the needs of the hospital and the community. And I think that includes, having the benefits of having a multi-specialty group have to do with the integration of, let's say, intensivists and hospitalists. You can have virtual integration. And I think ACEP needs to look at alternatives, not just having groups that have, where emergency medicine is cross-subsidizing these other specialties, but that maybe we improve quality, improve efficiency and safety and throughput, and still remain independent. I think there are still options out there. I hope there are. So.
Would you be willing to speak at our conference next summer?
Sure. And I got people in my group that are far smarter than me that could speak as well.
I will pass along my recommendations to the education team. But no, I appreciate your comments. And I learned a lot from starting our own group when we did we had a urgent care in a freestanding hospital, and it was eye-opening, coming from the academic world of the challenges of running a business, but of how important it is and how liberating it was, honestly, to be able to kind of see and set your own rules and kind of make your own group. Not everybody wants that, but we want to make people have choices and to practice in the environment that they want, and to have the transparency that they need to make a decision about where they feel happiest and which sort of practice environment that is. And I think that's what ACEP is really fighting for.
Thank you very much.
Absolutely. Well, thank you guys all very, very much for your time. This was the first week of school, so my kids are super excited to go pick them up. But this was wonderful. I really appreciate all the questions. And anyone who wants to reach out, please feel free to share my email through ACEP. I will also put in a plug that we have a website. It's acep.org/workforce, in which we have kind of updates. So as we make progress on any of those 5 pillars or have meetings with different people, we'll post those on there too. So you can kind of hold us accountable and see kind of all the stuff that we're doing to address everything that was brought up today. Great questions.
Yeah, I want to again thank Dr. Schmitz for joining us today. Really appreciate it. And I really want to thank each of you as members for showing up to this discussion and asking those very thoughtful questions. I think this is how we go ahead and evolve. Please don't make this your only opportunity to interject. Please come to any Cal ACEP board meeting. They are open to each of you, and really take it to heart that it's time to go and convince anyone who's not a member to join, because we are all in this together. They are going to be able to watch this if you want to encourage them as to how important it is. So this will be open access. But with that, we will close. And Dr. Schmitz, thank you for going over with us. We really do appreciate it.